Thanks, everyone. I'll just get these slides. That would be great. So we have a vision. So if you are, I wanted to say a senior, but maybe seasoned in health, and some of us are, you might call it Back to the Future. And if you're brand new, and like some of the students that I teach at the university, it would be really brand new and the future. So we do have a vision, and it's for community-based healthcare. So I'm very fortunate to work in an area that includes addiction, mental health, continuing care, primary care, have emergency medical services, and a host of provincial services. And so for the last year, we have been working on looking at what we need to do to shift to community-based care. And this will see Albertans' health and well-being improved through an integrated healthcare system that structures and plans around individuals and their communities and connects people to needed care and services. So I think you've heard a little bit about that this morning from various other speakers, and thank you for that. But in fact, we have a health minister, and you heard from our deputy minister this morning as well, that we do have a plan, and we do have a plan to move forward. The community-based healthcare is grounded in the principle that care begins and ends at home. And practically this means that health services that Albertans need will be accessible in areas and communities in ways, not necessarily always physically, but virtually even, to help support them and keep them healthy. It makes the continuity of care a priority. So these are some of the principles that we're looking at. Individuals are assessed and given the tools they need to link to other supports. So all things you've heard. And the community-based healthcare vision and the initiatives that support it will be helping us to look at financially sustaining our system, but also more importantly, providing opportunities for individuals like Jennifer's past grandma and probably parents to be able to have something that they can keep as records and be able to manage their own health. So I wanted to share with you a couple of things, and as I said, one of the areas that I have that I'm very fortunate to be overseeing is the addiction mental health area. So about a year ago, we released a report, or Dr. Swan and Larrabee released a report that said, what are the gaps, where are we at, what are the problems? And one of the things that we realized is that while mental health has many aspects of being a chronic disease, there are other chronic diseases that are affecting us in Alberta. So I have to share this because usually Dr. Lewanchuk and I are kind of co-chairing some of the discussions on primary care. So I asked him if I could use his statistics that he has worked with many of the analysts in this room around. So here's how it goes. A third of us are obese. A quarter of us will develop diabetes in our lifetime. A quarter of us will experience a serious mental illness sometime in our life. A quarter of us have high blood pressure currently, and we will all develop it if we live to an average life expectancy. All women will have developed osteoporosis by age 73. A fifth of us will be permanently disabled by neurological conditions such as stroke, dementia, or Parkinson's disease. So these are, and there's a few others, but I had to stop there because the fact of the matter is that we all are going to need the health system, and this is really important. And within the next 15 years, we will double our seniors population in Alberta. So these are really staggering statistics that say, how are we going to manage? What are we going to do? And what does this look differently? So planning for today, for the future, is going to be important. In 2014, there was a survey that suggested 50% of Albertans indicated they had at least one of their needs were not being met when they tried to get help. So we are very concerned about looking at the information, how does it flow, how can we do better, and then how do we prevent people from repeating their story multiple times. So this picture is actually an addiction mental health patient journey. So we've worked with Alberta Health Services and we've worked with a bunch of our providers to look at the journey. We have a really strong acute care piece. We have guidelines, we have assessment clinics, we have a number of places to go, particularly for those that have addiction issues, and we help people along the system. The patient is at the center, okay? We've said that, and we know that they're there. The problem is, if you look at the bottom part of the journey, there's a thing called primary care, and it's for all intents and purposes, absent. You may see your family physician or you may see a provider. In some of our primary care networks, of which we have 42, some of the services around mental health are very good. But every single piece along this journey, when we mapped it out, people had to give information over and over again. It wasn't connected, and it didn't follow, and they didn't have the information. So it was just an example of the service delivery is not coordinated, it is fragmented. And we have spent the last year, we started off with a deputy ministers group, and we have an advisory group of what started to be about 60 organizations and agencies, and we're now over about 150, and we have well over 200 people that come to every one of our meetings. So there's a very large groundswell around trying to understand how do we actually make this work happen. So we have information going forward, actually on this particular file, that will start to link in with our primary care, and will link with all of the organizations. So I'm sharing a little bit of snippets today, and you're wondering, how are they going to do that? Well, we do have a plan. We have a vision. We have a plan. So some of the things that I think that we will be definitely looking at. So this actually, if you can see it, and it is a bit faint, and we're going to have to work on this. At one of our mental health sessions, we had probably a room full of people this size, maybe double this size, and on the table we had paper. And we asked people to write ideas and thoughts, and there were a series of questions. It's a little bit like the cafe effect of how you gather people and get ideas. Someone drew this picture, and if you can actually see it, it is the community-based composition of the sectors. In the middle is the home, whatever that home is. And around there are fitness centers, there are hospitals, there are areas, primary care centers, which come in different forms in Alberta, and we have faith-based organizations, and we have everything that is connected to each other and to ourselves in communities. These communities can be large, they can be virtual, that doesn't necessarily mean all in one area geographically, but they are the components that make up our social services, our systems, our schools, that really become part of the community-based services. So looking at the policy shifts and changes that we need to make to do this, we realize that rather than trying to build our services based on how we have in the past, it is about the whole person and not the body parts. It's about how do we gather the resources and integrate, and then if you look at applying, and we will have to draw this picture out, but we had to take it off the placemat because it really, for us, it's a bit, if you know the Canterbury model, it's a little bit that, but this is our Alberta-made, this is our very much Alberta-made model. But in between those connections are the roads, whether they're the electronic roads or the systems that we are going to need to connect people together. So we realize that sessions like today are fundamentally important as we work through some of these various different groups. Our real vision is if we have Alice, the senior who's at home has multiple needs, is depending on social services or other community needs. If Alice needs to go to the hospital, Alice has a care team that follows with her and can make those connections back in and out of the community. So we don't have people sitting in high expensive facilities, which they're very much needed for, and we want to have, but rather there is some movement back so that there's supports back into the community. I will share this story, and because I think my boss has left the room, Dr. Amarine and I were up north, and we went to visit a facility. It was a brand new hospital, and it was actually quite a gorgeous facility, and in it were multiple services from the community. So it wasn't just a hospital. They had home care. They had a number of primary care networks and various different things co-located. And when he got out of the car, the people were always excited to see him there and came to greet him. And he said, where's the H for the hospital? And they were like, oh, we'll get right on that. We haven't got it up yet. And of course, what he was really saying, and he said to them, no, I'm actually kidding. I don't want to see an H on a hospital building anymore. I want to see the integrated health home approach. And if you want to call it something else, that's great. But it was signaling something different for the future. And these are really important. I'm going to share, I won't go through the benefits with you. I think we've heard them from the other speakers, but we do believe that balancing the shift from just even the kind of services that we have today. We have, as I said, 42 primary care networks. We have community health centers. We have bits and pieces of primary care in pockets. When we met with our addiction mental health groups, we realized how many people are delivering services on behalf of health where we're not connected and we're not having those conversations. So balancing some of our urban rural areas and also getting the right structures in places, it will be helpful. I'll just share with you the 5 strategic directions that we have for primary health care. And this is really our foundation for the health home. And again, having that home will be critical before we can actually start to apply other pieces. So we really see the health home as the place that people do go first and access services. And it can be mental health, it can be a number of other conditions. We also are looking at the range of services offered by teams of people. The first strategic direction, and this is actually as a result of several sessions that we held last year with a group of stakeholders to say, tell us a little bit about what does this primary care thing mean to you? So bringing about the cultural change is one of our big strategic directions. And again, this is really, we heard a little bit from Imagine, and we have actually, and we'll be engaging with them to do a little bit of more citizen engagement with us because people, and Albertans specifically, don't know really what this means for them, what the direction is, and we have to have conversations. They only know what they know, and they go where they go because that's what we have had historically. So increasing some of the interdisciplinary teams, fostering innovation and partnerships is going to be a big part of us shifting some of this cultural change and trying out different things. Enhancing the delivery of care between their families and the team care providers. The third block is around the blocks for change and how we are going to be leveraging some of the things like the technology systems. You'll hear a bit more about the primary care workforce, which is broadened. We're looking at expanding groups like the paramedics and other providers to do and provide services. And then also having some effective evaluation and quality assurances. I always think that, and I was going to insert a slide in here, it's always, well, having come out of a public health background for a number of years, I always thought it was always good to have a bit of a crisis because it kind of really forces you to do things differently. So when I look at things like our outbreak management systems that we've put into place and liberating some of the immunization data into NetCare, it was really trying to manage outbreaks was very, very complex because every provider had their own systems of information. We had to go to paper, pencil, emergency departments. We had sentinel physicians that were sending in information, and it was all coming in from different ways. I remember specifically, I think it might have been H1N1 or probably, or it might have been one of our big outbreak years where I came in after a weekend and there were 900 lab reports, paper-based, that people had to go through and enter into a system so that we could actually know if there was an outbreak. So we are way past that now, but without the cooperation of multiple groups, we don't actually get to where we have to be. And I think we have most recently have been looking at the opioid crisis and having to pull together information from so many different sources and other ministries to be able to answer questions that it becomes even more important for us as we're moving on this design. And of course, the last one is around the cultural needs and increasing value, return on investment. So every hour in Alberta in health, we spend $2.3 million. That's $56 million a day. So that's a staggering number. That is what we spend, and this is why we're also looking at shifting how we do this and how we work with others to do this. So the last couple of slides I'll do very quickly is really just to ground us around the vision of health home. And health home has many definitions. Our vision is that Albertans would have a relationship, an attachment. We've heard quite a bit from, as I mentioned, my colleague Richard Lewanchuk, who says that if you have a provider, if a person is attached, you actually have better outcomes. And when you look at all of the various different chronic diseases that I mentioned, we have an ability to take a look at what this means and then have the services within that group of providers available so that they're coordinated. The creation of a health home is, I guess there's 5 components. One is the integrated multidisciplinary care teams, integrated social and healthcare systems. So one of the advantages that we have in working on all of this work right now is working with multiple ministries, and there's very much a concerted effort to do that. Planning and structuring health services around people in their community, providing the tools and enablers such as the information systems, and again, shifting away from our thinking around buildings and looking at things that link people, whether it's electronic or whether it's through their providers in a continuous way. So the last slide that I'll just provide, again, as I mentioned, having both the relationship to the provider allows us to then take a look at the next informational continuity, because then we actually can have information going into systems and document information to trend not only how people are doing today, but how they're going to be looking tomorrow. So that's our policy shifts, and I've given you just a thumb sketch, nail sketch of what it looks like, but it will involve a couple of different things that looks at coordinating some of our primary care work, our PCNs with Alberta Health Services, who are also a big provider of services. So as Bill was mentioning, Ted Braun, who works at Alberta Health Services, and myself and our teams are working very hard to look at the aspects of continuing care and what that means in terms of keeping people and seniors in their homes, what it means in terms of mental health and addictions across the spectrum, and then how we build on the community-based care that we need to do into the future. So I'm going to pause there. That's our policy shift. That's where we're heading. You'll see a lot more about this in the next coming months, and look forward to answering questions at the break.
There was, if there was a couple of quick questions for Kathy. She'll be participating on the panel also at the end, but thanks, Kathy, for providing that context, which I think the integrated health information is one avenue which is going to be important for foundational besides the governance and delivery relationships. There's just a question right here at the center table.
I'm Maeve O'Byrne from Calgary. The picture that you showed still bothers me because it had primary care all off by itself. It didn't have pharmacy in there. It was missing some things too. So I think we need to think of it as being more integrated than what that picture showed.
Sure, you pull it together, yeah. Just pull it to you.
Thank you for that. I debated about sharing this. This isn't the perfect picture. And absolutely, pharmacies should be on here. We could have drawn a lot more pictures. So, you know, I appreciate that feedback because we're trying to capture, and we've had lots of different pictures on this. We were just trying to capture that it isn't a doctor's office. It isn't a hospital. It isn't it is a combination of all of those providers. So we will add, for those in the room, I think that we could add a few other pictures on here, and certainly thank you for pointing that out. I think it was more the concept that we were trying to illustrate. Thanks.
Okay.